Okay, this is presentation on Lasix. So this is Bill Wilson. He's a 65-year-old male, presented to the emergency department with shortness of breath, +2 pitting edema, bilateral lower extremities. Um, he's traveling through the Mountain West right now. He's from Florida, and he is currently non-compliant with his daily oral Lasix due to being on a tour bus trip and not wanting to pee constantly. Past medical history, hypertension, hyperlipidemia, coronary artery disease, and heart failure with a reduced ejection fraction. Um, Allergies, bee stings, mild, no anaphylactic reaction. Home meds, like we said, he takes furosemide every day, 20 milligrams, takes 10 milligrams of atorvastatin before bed, and he takes lisinopril 20 milligrams BID. Drinks 3 or 4 times per week, mostly beer, no history of alcohol abuse, never smoked, and never participated in recreational drug use. So yeah, like I said, presented with shortness of breath and worsening pitting edema, bilateral lower extremities. So the med we'll focus on is furosemide, trade name Lasix. It is a loop diuretic that acts in the loop of Henle, blocks the reabsorption of sodium, which causes water and sodium to be excreted from the kidneys, which is that common side effect that folks don't enjoy of peeing more. Indication for uh, Mr. Wilson is his pulmonary edema, shortness of breath, the pulmonary edema that's causing the shortness of breath, and his lower extremity edema. And then the therapeutic effect that we're looking for with him is diuresis that leads to reduced edema in the body and reduced fluid in his lungs, which would improve his oxygenation. So before we uh, administer what will eventually be IV Lasix to Mr. Wilson, we're going to want to listen for his baseline lung sounds. You'd expect to hear crackles probably in the bases of his lungs. Check his potassium levels because one of the side effects of um, Lasix is that it's non-potassium sparing, and so potassium levels can drop, which means they need to be at a normal level and not below 3.5. We want to check his kidney function since this medication acts within the kidneys. Check his blood pressure. It's possible his blood pressure is going to drop, and this can result in orthostatic hypotension. So we're going to want to check his baseline blood pressure, check his heart rate, make sure that's within normal limits, reassess his baseline bilateral lower extremity edema, check his baseline O2 sats, make sure he has adequate urine output prior to administering the Lasix. And then after we administer it, we'll want to get his baseline weight, and then we'll want to take daily weights after we administer the Lasix just to ensure that the medication is working. We would expect to see an offload of fluid, which would cause a drop in his weight. And then another adverse effect of Lasix, not common, but it can happen, is ototoxicity. So we're going to want to ensure that we have a good baseline for hearing. Um, Primary contraindications, allergy to Lasix or anuria. So again, because the medication works in the kidneys, if the patient is not urinating, that would be a contraindication. And then, like most drugs, hepatic or renal disease, just as these medications are metabolized in the liver and then excreted through the kidneys, we want to make sure that we've got a good um, that levels like our AST, ALT are within normal limits, and that our creatinine clearance is also within normal limits. Like I said before about blood pressure potentially dropping and causing orthostatic hypotension, we're going to want to ensure that our patient changes position slowly after they've taken the Lasix, and make sure that they do not stand up too quickly, get dizzy, and have a fall or potentially pass out. Um, Drug interactions primarily with aminoglycosides. There's no indication for infection with this patient right now. He's not taking any antibiotics. So with our safe administration practices, we have the right patient. It's Phil Wilson. We have the correct drug, furosemide, also known as Lasix. The route will be IV. His dose will be 40 milligrams. Time is now, and his indication is his CHF exacerbation due to his noncompliance with his daily oral Lasix. We're hoping the therapeutic response is that his pulmonary edema is reduced or eliminated, and that same with the bilateral lower extremity edema. And I mean, he knows the medication, but he's also been informed of the potential side effects from the medication. He's been offered the chance to refuse the medication, and he accepts. When prepping IV Lasix, it does not need to be diluted. You're going to be drawing up the IV push utilizing standard procedures and precautions. And we're going to administer it over 1 to 2 minutes. If it's pushed faster, it can cause that ototoxicity. Um, Mr. Wilson does not have any barriers to taking the medication, his home medication, especially due to cost because the medication is affordable. He's just not taking it because he's currently on a tour bus going through Yellowstone, and he doesn't want to be peeing constantly. Um, so that would be his potential barriers to adherence. And we'll just ensure, as we're educating Mr. Wilson on the treatment plan, that he has a good baseline understanding related to his heart failure and why the fluid, because his heart is pumping inefficiently, the fluid is backing up into his lungs and then also backing up into his venous system as well. And we'll also want to ensure that he's aware that he needs to continue following up with his primary care provider related to his home dosing on his Lasix to ensure that he has therapeutic potassium levels and that his kidney function is not declining. So, patient education in terms of taking his home Lasix, he's going to want to take it in the morning. Like I said, he'll want to have his labs drawn at regular intervals to ensure that his potassium and his creatinine clearance are within normal limits. Because of the potential for hypokalemia with this medication, he's going to want to report any sort of chest pain or arrhythmias to his healthcare provider and potentially seek, if these continue, seek a higher level of emergency care. Another reason or another cause for concern would be certainly decreased urinary output. He's going to want to monitor for weight changes. So greater than 2 pounds per day or 5 pounds per week would be something that he would want to report to his healthcare provider. He's going to want to change positions slowly. So from laying to sitting, sitting to standing, rather than going straight from laying to standing. He'll want to regularly monitor his blood pressure, his heart rate, and his respiratory effort related to potential backing up of fluid into his lungs causing pulmonary edema. He'll want to report signs of ototoxicity, like hearing loss or ringing in the ears, to his healthcare provider. And he will want to ensure to eat a potassium-rich diet. And then, depending on how he's presenting in terms of consistency of edema, whether it's in his lower extremities or the pulmonary system, he may want to consider implementing a salt-restricted diet so that he's not holding on to nearly as much water or I guess if his blood pressure is going up as well. After he takes the Lasix, like we said, we're going to want to regularly monitor the potassium levels. This will be something that will be important when we're in the hospital setting and he's taking the IV Lasix. I would anticipate that the provider would order daily labs to be taken. We're going to want to monitor strict fluid intake and output, along with those daily weights. We're going to want to monitor BUN, creatinine, make sure that kidney function is still good. Monitor for signs and symptoms of ototoxicity. Keep monitoring his blood pressures, his lung sounds, and his heart rate to ensure that the medication is therapeutic. Timeline. So IV Lasix acts pretty immediately. So we'll want to follow up on his vital signs probably within the first 20 to 30 minutes. And then, within the first 6 hours, and then probably just Q6 after that. Um, and yeah, well, because, like I said, because Lasix is non-potassium sparing, we're going to want to monitor his potassium levels. Um, and if he is showing signs and symptoms of hypokalemia, like experiencing arrhythmias, we're going to want to let the healthcare provider know, and they may order an EKG as well as another round of labs. If his potassium is low, they may order either an oral potassium pill or even IV potassium. And then you would want to monitor for signs or for confusion just in case his sodium level ends up dropping. That's not as known and common a side effect as hypokalemia, but it does happen as you're urinating, um, and as your urinary output is increasing, and your electrolytes maybe or will be going with them, including sodium. And then as soon as this acute event is over, so the pulmonary edema is eliminated, bilateral lower extremity edema is eliminated or at least returned to baseline, the patient is going to want to resume their normal home dosing. So the side effects, the minor ones, increased urinary output, that's an expected side effect. The patient should know about that, especially because they take the medication at home. Orthostatic hypotension, like we talked about, changing positions slowly. You're going to want to watch out for signs and symptoms of toxicity, like ringing in the ears. Leg cramps could be an indication of hypokalemia. Weakness and fainting just from the offloading of all that fluid could cause a drop in blood pressure. Same with dizziness. Hypokalemia being the major side effect. Hearing loss certainly as well. And then other less common side effects would be leukopenia, anemia, and thrombocytopenia, which can be monitored through daily labs. Um, we're going to manage these side effects by ensuring that the IV Lasix is not given right before bed, so that the patient is not constantly waking up throughout the night to urinate. So we give it in the morning, or at least early afternoon, whenever we can, to uh, help the patient out and make sure that they're remaining adherent to their medication. And then manage the potential for falls by changing positions slowly. Um, and once the patient heads home, good things to keep in mind to inform them to report to their healthcare providers: dizziness, fatigue, increased bleeding, hearing loss, weight loss, like we talked about those numbers, weakness, leg cramps. Um, and yeah, the most common adverse reaction is hypokalemia. So, leg cramps or arrhythmias is what we want to monitor for. Have your potassium levels checked regularly, maintain a potassium-rich diet. And then patients just need to know to expect that increase in urinary output and take the medication in the morning. Um, Riggle et al. Did find that 84.7% of patients just discharged from the hospital after a CHF exacerbation continued to be adherent with their diuretic medication regimen. So if we do good patient education and ensure that they have them do teach back to us, ensure that they understand their medication regimen, why it's important, and how they keep themselves healthy moving forward, utilizing their medication, it has a great success rate of patients not being readmitted. And then issues that we may run into in terms of an emergency response. Um, so if we look at the ABC model, the medication shouldn't, unless they have an anaphylactic reaction, shouldn't affect their airway. In terms of breathing, their gas exchange should improve as the pulmonary edema is reduced. Circulation, just the potential for low blood pressure is what we'd be most concerned with, or even the arrhythmias if they do become hypokalemic. So like I spoke about before, oral or IV potassium may be given if they're hypokalemic. If their blood pressure drops too low, I think the provider may give isotonic fluid resuscitation. I think that does depend on where their heart failure is at that point in time and whether that would actually be therapeutic or not if their blood pressure is low, or if the heart would be so weak that medication would just back the venous system up more. but we should be seeing an improved oxygen saturation as the fluid is offloaded and from the lungs, and decreased work of breathing, improved lung sounds. If patients do lose consciousness due to whether it be an arrhythmia or low blood pressure, as the side effect, we may want to consider calling a rapid response. And if that patient does have an arrhythmia or there's a potential for an arrhythmia, the provider may initiate cardiac telemetry. When we're talking to a provider, we're going to utilize the SBAR format: situation, background, assessment, and then recommendation. So the situation would be 65-year-old male admitted for CHF exacerbation. Its background would be history of coronary artery disease, hypertension, heart failure, recently received 40 milligrams IV Lasix. Upon assessment, they've got bilateral crackles in the bases of the lungs, 2+ pitting edema, bilateral lower extremities. Recommendation would be to continue to monitor for signs and symptoms of reduced fluid volume overload. We'll continue to monitor strict eyes and nose, daily weights, blood pressure, heart rate, respiratory rate and efforts, and electrolyte levels. Potential medication errors would be either would be potential prescribing error. So whether that's the wrong medication or the wrong dose, the wrong route, or if we don't obtain an accurate allergy history and the patient actually has an allergy to Lasix. So those are medication prescribing errors that, as nurses, we will be in. It's important for us to be the last line of defense for our patients there. Also, just monitoring that they do have safe lab values. So uh, pharmacies should also be looking at that, but we are another protection level for the patient. Make sure they have safe potassium levels. To recap, all found that 30 to 70% of provider prescribing errors are found by either nurses or pharmacists before the medication is administered. If a medication error is made, it should be immediately reported to the charge nurse and the physician. MITE's incident report should be filled out that the internal quality department can examine and check where the failures occurred and how this medication error can be prevented in the future. Here are the resources. Thanks so much.